Hello everyone, welcome to our channel. In this video, we are going to talk about peripartum cardiomyopathy. Peripartum cardiomyopathy is nothing but decrease in the systolic function of the heart, which occurs usually in the third trimester of pregnancy or postpartum. So, in the postpartum period of next 5 months. So, what is peripartum cardiomyopathy? So, what happens here is the systolic dysfunction, that is the pumping capacity of the heart decreases. So, usually, as you can understand, when the pumping capacity, so this is the normal heart, and this is the heart of a pregnant woman, pregnant female, or 5 months postpartum, right? So what happens here is pumping capacity has decreased and there is dilatation of heart chambers. Usually the pumping capacity is another term for the systolic dysfunction, right? So obviously the ejection fraction will decrease to less than 45%. So normal ejection fraction is more than or equal to 50 to above 50%. So here the ejection fraction has decreased. So as you can see, the size of the heart has increased and the ejection fraction has decreased. Because of the dilatation of the chambers, the pumping capacity has decreased. That is nothing but systolic dysfunction. Right? Understood? Now, let's write the exact definition for it. Peripartum cardiomyopathy. Let's refer it to as PC. Peripartum cardiomyopathy is LV systolic dysfunction, right? Or decrease in LV ejection fraction to less than or equal to 45%, right? In last month of pregnancy. Usually this occurs in the last month of pregnancy or 5 months postpartum. With no pre-existing LV dysfunction. That is, the pre-existing LV dysfunction must be ruled out, or any other etiology for heart failure. So what happens here is when the chambers have dilated, as you can see, the LV has dilated. This is RV, this is LA, and this is RA. So when the LV has dilated, it is unable to pump the enough amount of blood into the aorta. When it can't pump enough amount of blood into the aorta, blood remains within the LV, which is on increase in the pressure in the left ventricle. This is transmitted into the left atrium. So the left atrial pressure also increases, resulting in increase in pressure within the left atrium. That results in increase in pressure in the pulmonary veins, which result in increase in the pressure of pulmonary capillaries, resulting in pulmonary edema. So this is how the patient presents with heart failure, right? And as you can see, the right ventricle has also enlarged. So when the right ventricle enlarges, the pressure is transmitted into the increased pressure is transmitted into the right atrium. And when the right atrial pressure is increased, the pressure is transmitted through the superior vena cava and the inferior vena cava. And when the inferior vena cava pressure increases, the patient presents with this is transmitted to the lower extremity veins. This results in the pedal edema. So the left heart failure, that is LA and LV increased pressures, result in pulmonary edema, whereas the increase in pressures in right atrium and right ventricle result in lower extremity edema, hepatomegaly, etc. So this was the pathophysiology of heart failure in simple terms. We'll discuss this later in another video. Now coming to the etiology of peripartum cardiomyopathy. Well, the etiology of peripartum cardiomyopathy is likely multifactorial, and all the next below things may contribute to peripartum cardiomyopathy. So that is genetic predisposition, nutritional deficiencies, autoimmune process, viral myocarditis, and hypertensive disorders of pregnancy, that is preeclampsia and eclampsia. So this preeclampsia is known to be strongly associated with peripartum cardiomyopathy, that is the strong risk factor, because both of these conditions have elevated levels of SFLT1 levels. So this is a chemical compound which is elevated in both the preeclampsia patients as well as peripartum cardiomyopathy. Hence, the preeclampsia is thought to be the strongest risk factor for peripartum cardiomyopathy. What are the other risk factors? Advanced maternal age, of course, multiparity, that is more number of pregnancies, multiple pregnancies. So the difference between multiparity and multiple pregnancy is this includes twins, triplets, etc. Or the hypertensive disorders of pregnancy, which include preeclampsia and eclampsia, right? And also African ancestry. So this has to be this was noted more in the African woman. So that's why this is also one of the risk factors. Now, how does the patient present and how do you diagnose it? The clinical presentation. Well, the pregnant female will complain of dyspnea on exertion and pedal edema. But as you know, the dyspnea on exertion and pedal edema are most common in the last trimester of pregnancy, so it is difficult to differentiate. So it is difficult to diagnose. So when a pregnant female complains of dyspnea on exertion and pedal edema in the last trimester of pregnancy, everyone will be saying that it is due to the pregnancy, due to the pregnant pressure of the gravid uterus on the inferior vena cava, resulting in increased pressure in the lower extremity veins, resulting in pedal edema. And the dyspnea on exertion may be contributed due to the upward push on the diaphragm of because of the gravid uterus. So these two may also result in dyspnea on exertion as well as pedal edema. So it is difficult to diagnose, difficult to differentiate between the basic complaints of pregnancy and peripartum cardiomyopathy. And the patient might also present with signs and symptoms of heart failure, which can range from mild to sudden cardiac death. As you know, the pregnancy is also a hypercoagulable state, so thromboembolic risk is also increased. Thromboembolic event risk is also increased. That is, the patient might present with DVT or pulmonary embolism. So how do you diagnose it? If you do lab investigation, the pro-BNP level as well as anti-pro-BNP level are high. And if you do an ECG, you will note there is LVH, left ventricular hypertrophy, and ST wave abnormalities. And if you do a 2D echo, that is transthoracic echo, it will show a reduced ejection fraction of less than or equal to 45%, along with dilatation of chambers, dilatation of all the four chambers, and functional MR may occur due to the dilatation. When LV is dilated, of course, there will be dilatation of the annular ligament of the mitral valve, resulting in functional MR, right? And LV thrombus may be seen. Of course, pregnancy is a hypercoagulable state, and combined with the decreased ejection fraction, LV thrombus may be seen. So, how do you treat now peripartum cardiomyopathy? Just like any other heart failure, so the basic standard guideline directed medical therapy should be used. So, what are included in this? So, first thing is BP and SpO2 monitoring, cardiac telemetry to look for the rhythm, to look for rhythm, and then oxygen supplementation, and then IV diuretics, titrated according to BP, right? Now, the catch here is ACE inhibitors and angiotensin receptor blockers, which are mortality reducing drugs in heart failure, are contraindicated in pregnancy. So, in place of ACE inhibitors and ARBs, we use these. So, these are not used. We use nitrates and hydrolysine. Like if the patient's BP is good, the patient's BP's blood pressure is on the higher side, we can give IV nitroglycerin infusion, right? And another mortality preventing drug, as you know, beta blockers, right? These are safe in pregnancy, and specifically metoprolol, carvedilol, and bisoprolol. These are the cardioselective drugs, and these can be given in pregnancy. These decrease the heart rate, decrease the incidence of arrhythmia, and decrease the risk of sudden cardiac death. So beta blockers have a lot of importance in peripartum cardiomyopathy. Another catch here is digoxin. Surprisingly, this is safe in pregnancy, and this may increase the pumping capacity of heart. So this may augment contractility of heart, and for also the heart rate control. But the catch here is, as you know, digoxin toxicity is very common, so levels must be monitored. Another thing is, as we know, pregnancy is a hypercoagulable state with an increased tendency to form LV thrombus. Anticoagulation is a must. and usually low molecular weight heparin is preferred. And in non-breastfeeding women, direct oral anticoagulants may be considered, right? So, if the pumping capacity of the heart is decreased in a pregnant woman or in the postpartum period, that is of the first 5 months, does the pumping capacity return to normal or it remains the same? Well, good question. So the answer to this is the extent of the ventricular recovery at 6 months post delivery. It predicts the overall recovery. So 6 months post delivery or 6 months after the diagnosis of peripartum cardiomyopathy, the ventricular function gradually returns to normal, or even if not normal, it may come near to the normal value. So LV functional recovery may occur 6 months after diagnosis, and continued improvement has also been noted 2 to 3 years after the diagnosis. So if a pregnant female was having an ejection fraction of 53%, suppose, so after the diagnosis of peripartum cardiomyopathy, after a period of 6 months, so in the peripartum cardiomyopathy, ejection fraction patients was 43%. So after the diagnosis of peripartum cardiomyopathy, within a period of 6 months, it may return to normal value or at least around the normal, that is 50 to 53%. And continued improvement is also noted 2 to 3 years after the diagnosis. So this is the explanation for that. So let's revise it now. Peripartum cardiomyopathy is nothing but the LV systolic dysfunction or decrease in the ejection fraction by less than 45% in the last month of pregnancy or 5 months postpartum with no pre-existing LV dysfunction or any other etiology for heart failure, right? Etiology is multifactorial, genetic, nutritional, autoimmune, viral, and preeclampsia and eclampsia. So the preeclampsia is the strongest risk factor because both have been noted to have an increased levels of SFLT1, right? Risk factors. Risk factors include advanced maternal age, multiparity, multiple pregnancies, preeclampsia, eclampsia, and African ancestry. So the clinical features. In a pregnant female complaining of dyspnea on exertion as well as pedal edema, it is difficult to diagnose because these are also the common complaints which are seen in the last trimester of pregnancy. So the signs and symptoms of heart failure may range from mild to sudden cardiac death. 2. Thromboembolic event risk is also increased, for example, DVT and pulmonary embolism. Lab values include proBNP increased and NT-proBNP is also increased. ECG suggestive of LVH and STT wave abnormalities. 2D suggestive of decreased ejection fraction, with decreased left ventricular ejection fraction and dilatation of all the four chambers, functional MR and LV thrombus may be seen. Treatment is just like the treatment of any heart failure, oxygen supplementation as well as IV diuretics. But ACE and ARBs are contraindicated in pregnancy, so in place of them, we use nitrates and hydralazine. And beta blockers are safe in pregnancy, especially they decrease the heart rate, they decrease the incidence of arrhythmia, and they decrease the risk of sudden cardiac death. Digoxin is also safe in pregnancy. We use it to augment contractility of heart and for controlling the heart rate, but its levels must be closely monitored. And anticoagulation is preferred in pregnancy. It is low molecular weight heparin, and in non-breastfeeding, direct oral anticoagulants may be considered, and the LV function may return back to near normal levels within 6 months after the diagnosis, and the continued improvement has also been noted 2 to 3 years after the diagnosis.